Right, well, thank you very much and good morning everybody. We're going to set the scene with a basic principles talk, which I guess will be particularly relevant for those of you that are more junior registrars, but also I've put a few controversies in there to get some of the more senior guys thinking a little bit about different ways of doing things. So we're going to talk a little bit about the initial general management principles for foot and ankle injuries when you first meet them. We're going to talk specifically about open fractures, because that includes a proportion of patients that you'll meet. We'll talk a little bit about some controversies with how to manage the fracture dislocations of the ankles, a little bit about whether we cast or splint simple fractures. I'll mention foot compartment syndrome briefly, and simply just because it's really common and because there's talks about the later implications, I've got a few slides on lateral ligament sprains in the ankle. Anything that I think is really important is highlighted in yellow, and anything that I think is a useful top tip for you to take away has a little top tip sign by it. So general principles first. The single most important tool that you have at your disposal is the ability to take a good, careful history and to perform a thorough physical examination of your patient. And in particular, I think some of the things you need to pay attention to are the mechanism of the injury. How did it actually happen? And get as clear a description as you can from your patient of how they came to injure themselves. In particular, what you're interested in is what force was applied to the foot or ankle and in what direction. The ability to bear weight or not after the injury is a useful piece of information because it tells you whether the patient may have a stable or an unstable injury. And the location when you first meet them in the emergency department of the bruising, swelling and tenderness to palpation can tell you a lot about which structures have been injured. And when you see them subsequently in the fracture clinic the next day or the day after, that bruising will have spread out. And so somebody else who sees the patient later may be able to make a less accurate clinical assessment than you can when you first meet the patient. Medico-legally, of course, it's important to document the neurovascular status, and one of the things many hospitals can do these days is to put photographs of the injured limb on the electronic patient record. Certainly in our hospital, the ED has a digital camera where they routinely upload pictures of open wounds, of deformed ankles and things like that, so we can subsequently look at them at our trauma meeting. Your clinical examination obviously should be supplemented by adequate radiographs, and in many emergency departments now it's fairly easy to get a CT scan done quite quickly if you need it to assess an injury. So here's the first top tip. If you see a foot with plantar bruising, it's never due to a sprained ankle. And there are various injuries which can produce plantar bruising, but one example is this here. This is a patient who came into Derby not so long ago and actually turned out, I'm sorry, the laser pointer doesn't point at TV screens. You can just see here, there's some subtle widening between the base of the medial cuneiform and the second metatarsal. This is a Liz Frank injury. And although the photos of a different patient, this is something you sometimes see with Liz Frank injuries. So don't discount plantar bruising. It means there's something going on. Here's another little tale of woe. This lady was sent home from our emergency department, I'm sorry to say. She'd fallen off a horse. She had a pretty sore ankle. The ED doctor looked at the x-ray and said, well, I can't see anything there, off you go. She came back a couple of days later, said, no, my ankle really is very sore, and it was very bruised and swollen because I went round from my fracture clinic to see her. And in fact, she's got a smashed talar body, so quite a severe talar body fracture. So the next learning point is a patient who can't bear weight on their foot or ankle has a significant injury, and you have to listen to what the patient's telling you until you've proven otherwise. When we're dealing with multiply injured patients, everybody gets very excited about saving their life and dealing with ABCs and going through the ATLS primary survey, etc., etc. In this context, of course, foot and ankle injuries usually take lower priority, but because of that, foot and ankle injuries can easily be missed. So it's really important to do a thorough secondary survey, or several secondary surveys, until you're absolutely sure that there isn't a foot and ankle injury. Because once you've saved their life and fixed their femur, or their pelvis or drain their hemopneumothorax, you can bet your life that 6 months later, the thing that's going to be giving that patient the most trouble is their foot injury, the Liz Frank injury that you missed. Okay, so that gets a yellow box. So here's a patient again, who came into Derby a couple of weeks ago. Everybody was very excited. He'd been T-boned by a car on his motorbike, and everybody was very excited about this completely smashed distal femur proximal tibia with a massive open wound. To be fair, they did pick up that he had a slightly sore foot, and they took this rather inadequate x-ray. And people said, well, it's probably all right, and it kind of got forgotten about. And then I got asked to go and see him about a week later on the ward. He'd had his preliminary fixation of his femur and his soft tissue reconstruction. And actually, again, you can see, he's got a Liz Frank injury. So luckily, we picked it up and we were able to fix it for him. The general principles of the initial treatment are listed here. Analgesia and reduction in splintage actually probably are the same thing. The single most important thing you can do for an injured limb is to reduce it into the best possible provisional position and splint it there. That's the best pain relief you can have. Open injuries need IV antibiotics as soon as possible, and they need initial decontamination, and usually that just means getting a litre bag of saline, cutting the end off it and emptying it over the open wound just to wash off the superficial debris. Photos, as I said, are very useful, and then the open wound should be covered with antiseptic dressings. There are some groups that I think you should be particularly aware of because of their propensity to do badly. The elderly, because of their fragile soft tissues, have higher complication rates. Diabetics, and particularly diabetics with neuropathy, will always punish you if you don't do everything absolutely by the book. And even if you do, sometimes they will. Alcoholics and drug abusers, sadly, are quite common in our emergency departments. They're a particular problem because the alcoholics have poor bone quality, so their bones are difficult to fix, but also they're a very non-compliant group, and they won't do what you ask them to. And the other patient group is the unconscious patient, because then it becomes like veterinary medicine. You can't take a history, so you're working blind. You don't know exactly what happened, and you have to use all your other clinical skills and imaging to try and work things out. And this is a particular thing to be aware of. The diabetic who's had a little bit of a trip or a stumble a couple of weeks ago and presents with a rather angry looking foot. This is acute Charcot-arthropathy. It's not cellulitis. Don't miss it. Always ask about diabetes. There are some controversies which I'd like to zip through. With open fractures, when do we take them to theatre? We always used, when I was a registrar, we always used to do them in the middle of the night if we could. But more recent meta-analyses and studies have suggested that early antibiotics are the single most important factor at preventing infection. And if you read the BOAST-4 guidelines, which you should all be aware of from the BOA and BAPRAS, their recommendation is that where possible, surgery should take place on a routine trauma list with a senior orthopaedic surgeon and, if necessary, a plastic surgeon. Having said that, the 6-hour rule, or get to theatre as soon as you can at least, still applies for very severely contaminated injuries, because there's probably a lower infection rate. There are some injuries which are so severe you'll wonder whether the patient needs an early amputation, and sometimes, like this foot, which is completely degloved, the decision is fairly easy. But sometimes it isn't, and you need probably an opinion from 2 senior doctors to make the right decision. Sadly, there's nothing that really predicts the outcome with limb salvage or amputation. Having an insensate foot doesn't necessarily predict unsuccessful limb salvage, and there's no injury severity score that really gives you a good indicator of whether you can salvage a limb. If you're going to do an amputation though, it's best done fairly soon, within the first week or 2. So a little bit about fracture dislocations of the ankle. There is argument about whether you should reduce a deformed ankle first and then x-ray it, or whether you should x-ray it first to see what the injury is and then reduce it. And you have to make the decision on individual cases. Is there skin tenting? Is there neurovascular compromise? How quickly can you get an x-ray of it? If the answer is yes to any of those, it's probably better to reduce it first. But the clinical problem you will occasionally encounter is that you reduce the ankle, you take an x-ray, and it looks completely normal, and you can't see a fracture. And a proportion of those will actually be a subtalar dislocation. So I think if you find yourself in that situation, what you should do is a CT scan. And you will see little fragments of bone in the sinus tarsi from the subtalar dislocation. Where should you manipulate them? Well, again, it depends on what the arrangements are at your local hospital. But what you do need is the ability to deliver appropriate analgesia and sedation or anaesthesia, plastering facilities to put a decent cast on the leg afterwards, and it depends what the emergency theatre availability is in your hospital. If you can't get into theatre for 6 hours, you don't want to leave somebody with a dislocated ankle for that long. And what do you do if it's irreducible, if you can't get it back into joint, or you reduce it and as soon as you try and put a plaster on it redislocates? What's your strategy then? And that's a question I can't answer for you, but it's something you should think about every time you encounter a dislocated ankle and how you're going to manage it in your own hospital. What about the more minor fractures, such as lateral malleolar avulsion fractures, which are essentially a bad sprained ankle? The stable type B ankle fracture, like this one, you can just see there's a little undisplaced fracture line through the lateral malleolus, but the patient can walk on it. Fifth metatarsal tuberosity fractures and isolated single metatarsal fractures. You don't have to put them in cast, and I would encourage you to discuss with your patients, do they want to have a cast for pain relief, or would they rather not? Because if you have a cast on your leg, it does make the leg more comfortable, but it's a pain in the neck for going in the shower, because you get your cast wet or you have to put a bin liner on your leg. And many patients, given the choice, will actually decide not to have a cast on their leg. There are many devices like Darko shoes, other brands are available, which will actually make many patients with metatarsal fractures pretty comfortable. And they're cost effective, and you don't necessarily have to see your patient again in the fracture clinic. What you don't know if you don't put them in a cast is whether they comply with the treatment. But for these fractures, perhaps it doesn't matter. Foot compartment syndrome, I'm sure most of you will have encountered, but it's a source of much controversy. And there's a lot of disagreement if you look in the literature as to what it is exactly in terms of the number of compartments in the foot and the ability to formulate a good clinical diagnosis. Because when you use it for tibial fractures, it's fairly easy to say that somebody has muscle stretch pain, but when you wiggle the toes in somebody with an injured foot, of course it's going to hurt. So it's much harder to diagnose. There is no universal pressure, compartment pressure definition, so you can stick a pressure monitor into the compartments and measure the pressure, but there is no universally accepted definition of what pressure indicates compartment syndrome. Having said that, not to make a diagnosis of compartment syndrome when it's present is probably quite hard to defend medico-legally. So do you release it or do you not? I've had a patient recently who had bilateral calcaneal fractures and fasciotomies in his foot soon afterwards in another hospital, and then was sent back to me. And his entire management over the subsequent weeks was the management of his fasciotomy wounds. Haven't been able to get near his fractures. So releasing compartments has a high morbidity in the foot. They usually need skin grafts, and of course as a result the soft tissues can affect your bony reconstruction if you're planning one. So it may be the case that the treatment is worse than the condition. So just a few slides about the lateral ligament complex injuries and then I'll wrap up. Hopefully you're all fairly clear on the anatomy of the lateral ligament complex, comprising the anterior talofibular ligament, calcaneofibular ligaments, and the posterior talofibular ligament. It's a really common condition. 1% of all ED attendances are people with sprained ankles, and you know the usual risk factors. Sorry, I'll skip over that video. I'll show you later if you want to see it. The history is usually typical, and obviously the patient has lateral ligament bruising, swelling and tenderness. In the ED, the Ottawa ankle rules will help you to decide whether to x-ray it or not. And you can do an arthrogram and demonstrate the defect in the lateral ligament, although in practice I've never done it. You can argue whether we should be acutely repairing all lateral ligament injuries, and there are papers in the literature which show a lower incidence of late pain and instability. But can you imagine what would happen to all your trauma lists if we repaired all lateral ligament sprains that we saw? And the most important thing to remember is that selective operative treatment later down the line gives good results, and we'll hear more about that later. So the pragmatic treatment is to manage the swelling with the Ps, an early referral to physiotherapy, because not doing anything with a lateral ligament sprain does not count as treatment. You have to do something, and referring the patient to physio for proper rehab is important. And then selectively repairing the late presenting instability and laxity. And the other thing to say, I think this is a particular bugbear of mine, MRI scanning is not a tool for assessing the lateral ligament complex. It doesn't tell you whether the lateral ligament works or not. If you scan every ankle that's been sprained, it will tell you that the calcaneofibular ligament and the anterior talofibular ligament are thickened. There is a European consensus statement on ankle lateral ligament sprain, and I would encourage you to read this. It's fairly easy to download, and there's a lot of useful clinical information there. So in summary, we've covered some of the general principles of the initial management of foot and ankle injuries. We talked about a few of the controversies with open injuries, ankle dislocations, the minor injuries, and compartment syndrome in the foot. And I've talked a little bit about lateral ligament sprains. And I'm happy to take any questions.